When we administer anesthesia for a surgical procedure, the most important effect that we want to achieve is unconsciousness. We want the patient not to have any conscious awareness during the surgery, and therefore, of course, not to have any memory of what went on during the surgery.
But up to 1% of high-risk patients will have episodes of awareness during surgery and remember it later.
They remember that they were aware during surgery. And some of those memories are innocuous. They just remember something someone said. Perhaps it's funny, perhaps it was meaningless. But for some of these patients, they have very unpleasant memories. They may remember feeling pain. They may remember hearing things about the surgery that scared them. They may remember being paralyzed by drugs that we give and being unable to respond.
This study compared a technique that monitored brain activity with a bispectral index, or BIS monitor, to a method that measures concentration of anesthetic agents in a patient's system by monitoring anesthetic in the air that the surgical patient exhales.
We were surprised that there were fewer patients who experienced both definite and possible intraoperative awareness in the group that was randomized to receive the end-tidal anesthetic concentration protocol. We were unable to eradicate this complication completely. However, we certainly were able to have a much lower than predicted incidence of intraoperative awareness.
A potential difficulty with BIS monitoring is that the readings seen by the anesthesiologist don't reflect what's happening in real time.
It produces an index from 0 to 100, where numbers close to 0 suggest that there is undetectable electrical activity from the brain, and numbers close to 100 are consistent with the awake state. The index between 40 and 60 is the recommendation for surgical anesthesia. If you think about Stephen being under anesthesia now, so imagine he's anesthetized, which he's not, and which the bispectral index suggests to us with the number of 91. But imagine he was, and then I were to put a scalpel into his chest. He could be asleep now, naturally asleep, and the bispectral index would give you a number of 40 to 60, because it can't distinguish natural sleep from general anesthesia. When I put the scalpel into his chest, he would immediately wake up. Would it be acceptable for him to have 30 seconds or so of agony while I'm cutting him before the number changed, or would you want a faster response time? I am now cutting the bispectral electrode. Cut. Okay, so I've cut it, and you can see that the raw electroencephalograph has immediately become meaningless. There is no longer an electroencephalograph trace, but the bispectral index continues to have a meaningful reading of 85, suggesting that Stephen remains awake. So Stephen could have had 40 seconds of agony before the bispectral index monitor would have showed that a state change had occurred or that something dramatic had occurred.